the program platform. So it's 8 o'clock. Good evening, friends. At another session of the postgraduate clinics in general surgery. Today we have very important case, the left upper quadrant mass. It's going to be presented by Dr. Varun Dixit from the Himalayan Institute of Medical Sciences, Jollygrant. Is kindly contributed by Professor Hemant Natyal. And we have invited faculty joining us soon. We have Professor Sushama from NRA Medical College, Vijayawada. We have our own faculty, Dr. Kanna sir, Dr. Rajiv sir, Nishi sir, and others joining shortly. So as we have committed to the time, we will start the session now. So we have one long case today. So candidate will be starting the presentation. They will be running till the end of history without interruption. And then the faculty can go back and discuss each slides. Then again, the same thing happens with the clinical examination. And at the end of it, diagnosis and management can be discussed with. This candidate has taken operative pictures, imaging reports, and other things. So everything is available. So candidate can present the report and then the discussion can be taken it further. So thank you very much for joining. And I wish the candidate very best for the upcoming session. And thank Dr. Hemant sir for kindly permitting the postgraduate to join us today. And I also thank all the faculty for joining. So please take over. Good luck to you, Dr. Dixit. You please start your presentation.
Yes, sir.
Go to the first slide and make it full screen. Yes, you are good to go. Good luck.
Yes. Good evening, respected teachers. My name is Dr. Varun Dikshit. Thank you so much for inviting me for this session. I would like to thank Dr. Hemant Kumar Nautiyal, Professor and Head, Department of General Surgery, for guiding me in this case presentation. Today, I'm going to present a case of a 55-year-old female homemaker, resident of Udham Singh Nagar, Uttarakhand. She presented to us in emergency with complaints of pain in left side of abdomen over the past 10 days, with fever since past 9 days and multiple episodes of vomiting since 9 days. Patient was apparently well 10 days back when she developed pain localized to left upper abdomen, which was mild in intensity, dull aching in character, radiating to back, increased on coughing and straining. There was also complaint of heaviness in left upper abdomen. There was also history of malaise and fatigue since past 15 days. Patient also had complaints of intermittent fever, which was mild, documented to 99.6 degree Fahrenheit, associated with chills and rigor. There was no diurnal variation of fever. She also had complaints of multiple episodes of non-bilious, non-projectile vomiting, consisting of food particles, which was associated with intake of meals. Past history: patient was a known case of type 2 diabetes mellitus since 2013, and she was on regular oral hypoglycemic agent. There was also history of hypertension since 2013. There was no history of tuberculosis, COPD, or any other chronic illness in the past. Patient also underwent laparoscopic cholecystectomy elsewhere in 2013, for which the documents were not available with them. Personal history: patient was a non-vegetarian by diet, non-smoker, non-alcoholic, with no history of any other addictions. There were no significant history of malignancy in the family. Negative history: there was no history of any jaundice, history of any traumatic injury to the abdomen, of any altered bowels, history of burning maturation, or history of any bleeding per rectum. Based on the history, I would like to make these 4 as my provisional diagnosis, differential diagnosis: malaria, dengue, enteric fever, and tuberculosis.
Dr. Varun, this is Dr. Sai.
Yes, sir.
Let's start with the differential.
Yes, sir.
You think you are dealing with a medical case?
So based on history of pain, abdomen, and vomiting with fever, I would like to go for these diagnoses first.
So pain abdomen with vomiting, you think of malaria first. On left flank, pain abdomen.
Since there is no history of any altered bowel or bladder habit, loose stool or constipation, so we can rule out any intestinal pathology.
So what about genitourinary?
So there was no history of any burning micturition, as I asked the patient.
So why does it take you to malaria for all I know? I mean, that would be way down on my list. Malaria, dengue fever, enteric fever, tuberculosis of which place? Of the brain?
No, sir.
Where tuberculosis what?
So any secondary foci, any old history of contact with which patient did not give, but still.
Okay. Tuberculosis, you can get it, push it anywhere in your differentials, but tuberculosis of what? Okay, forget it. You have a patient, type 2 diabetes with hypertension, comes to you with mild fever, or is it high grade? What is the kind of fever?
Sir, intermittent low mild fever, 99.6.
Mild fever, right? Yes. So a diabetic female with mild fever, with pain, what will come to your on the pain on the left flank? What will come to your mind first? What are the causes of pain on the left flank in such kind of women?
So, since first of all, in these kinds of patients, it could be due to renal colic, but
okay, we will think of infections of the kidney.
Yes, sir.
First thing.
Yes, sir.
What else can cause pain on the left flank?
Sir, any pathology of the spleen, sir.
Okay, splenic pathology. What else?
And sir, since there is a history of chills and rigor present with fever, that's why I considered malaria.
चिल्ड्रन रहेगा यूटीआई यार सर्जन जैसा बात कर यार फिजिशियन का मत बात करो tuberculosis can there be can it be a psoas abscess cold abscess
Yes, it can be.
so
Yes.
so why you're coming with these I mean enteric fever how have you come to this differential I can't believe how have you come to enteric fever and dengue okay let's go back to your history first let's correct your history okay pain left upper abdomen so upper
Yes.
abdomen what are the structures there you have the
Sir,
kidney you have the stomach you have the spleen you have the
yes.
tail of the pancreas
Yes, sir.
right
Yes, sir.
and you have the splenic flexure
Yes, sir.
so you have to think of all these organs
Yes.
now which are the organs which can give you pain which is increase on coughing and straining heaviness with malaise and fatigue 15 days
Sir, was any splenic
was
abscess,
this
sir?
the first episode of pain did she have an history of pain before
No, sir.
this is the first episode
Yes, sir.
look with mild episode of pain and mild fever why did she come to the hospital
Sir, because of
for
because
these kind of complaints like that
sir,
there must
because
be something more.
yes, sir, because she was not getting relief when she went to a local hospital, so she went. Came to our hospital.
Was she referred from there
No, sir. So they directly came from the hills to our hospital, sir, our center.
okay but it's unlikely I'll tell you what and they would go to medicine first they won't come
Yes.
to this kind of thing was it referred to you from medicine
No, no, sir. She came in the emergency only, and
surgery emergency surgery
yes, sir.
okay fair enough can there be uh, uh, chest problems which lead to pain in the left flank with fever and all this kind of thing
Yes, sir. She can have uh, gastritis or acid peptic disease.
no what about chest she can have pleural effusion she can
Pleural
have
effusion. Yes,
pleuritis,
sir. Yes, sir.
right
Yes, sir.
so okay now let's go to your next slide fever chills okay right okay next slide please now why is she getting vomiting okay let's see okay did you just ask about any chest pain or any breathlessness
Yes, sir. I asked about any history of shortness of breath while walking, but any
okay next slide please you've not written anywhere that's why I'm asking you you've not taken that history look Varun
Yes,
if the history has been if you've taken it silently and kept it inside your pocket I won't know
yes,
I would
yes,
assume that you don't know you've not taken it okay
yes,
so
sir.
I think look taking history is like a getting out a puzzle right you got to focus what are the structures in that area what can give you these symptoms and then try and fix it so please
Yes.
Varun,
hello
hello,
class चल रहा
Hello.
hello, am I audible?
Yes, you are audible.
Tactile non-bilious vomiting. What does it signifies?
Sorry, sir.
Regarding the pathology, you have mentioned that there is a non-bilious vomiting.
Yes, sir.
What is significance?
So, patient had first of all pain radiating to back. Second, she had history of laparoscopic
Pain radiating
cholecystectomy
to
10 years
back.
back.
You have
So,
not mentioned that pain is radiating to back.
no, sir, I have mentioned it. Fourth point.
Hello.
yeah radiating to back is
Sorry. Okay. Pain
Yes,
is
sir.
radiating to back. Okay.
Yes, sir. And she had history of laparoscopic cholecystectomy 10 years back. So, based on these two indications in history, I took history of non-bilious vomiting also.
Hmm.
look, if you're thinking like pain radiating to back, you're thinking of pancreatitis,
Yes, sir.
then there will be multiple episodes of it. Can't be just first episode and she's gonna come.
Yes, sir.
Right? There'll definitely be on multiple episodes. I don't know whether you've taken history, whether she's got similar history in the past or not.
No,
Okay.
sir, she had, so over the past 10 days, she had multiple episodes of vomiting.
Over the past 10 days.
Over the
but not
past 10
before that.
days.
Okay.
By this your clinical presentation, which history we supposed to exclude, or which pathology we supposed to exclude, other than medical pathology? Other than medical pathology.
So
There
we
is a
can
pain in the
root
left side of the abdomen. You have mentioned that there is a pain in the left side of abdomen.
yes, sir.
Hmm?
So we can rule out
Along with fever,
intestinal pathology because there is no. So we can rule out any intestinal pathology because there's no history of any loose stool or constipation present.
Okay.
And
Other than this,
and so also apart from that, she also gave no history of any burning micturition. So we can rule out genitourinary or UTI also.
UTI.
So patient is a diabetic, so we had to rule out UTI also.
Pertaining to the left upper quadrant, any other thing you want to exclude? Gastric pathology.
So gastric pathology, it could be acid peptic disease, but there was then it would not have any vomiting until and unless there was obstruction at the level of gastric outlet or any features of gastritis, because it would not be a short history of 10 days.
Okay. Anything else?
And the was not relieved. Pain relief was not associated with food intake, so we can rule out acid peptic disease or gastritis.
Varun, Varun, can you hear me?
Yes, sir. Good evening, sir.
Yeah. In this surgical forum,
Yes,
when you are presenting a surgical case, probably you are not going to keep the malaria and the dengue as the first diagnosis.
yes, sir.
Okay, you have to think of surgical causes for what you have described. Patient is having the
Yes,
pain
sir.
in the left upper abdomen. She has fever. The pain is radiating to the back.
Yes,
There
sir.
is pain associated with the respiration.
Yes,
So you have
sir.
to think of the things that can surgical causes for that.
Okay, sir.
And you have to think in terms of pancreatitis. You have to think in terms of the pleuritis.
Yes, sir.
You have to think in terms of the,
Yes.
because the patient is diabetic. So it may
Yes,
be,
sir.
even if the patient does not have the dysuria, there
Yes, sir.
can be a diabetic emphysema may be there of the kidney.
Okay, sir.
Okay, all these things can cause, or there is splenic pathology is there.
Yes, sir.
That there is some
Splenic
infection in the
abscess.
spleen is there. Okay.
Yes.
So these are the surgical causes which has to be coming out first rather than keeping the malaria and the dengue as the first diagnosis.
Okay, sir.
Okay. Yeah.
Yes.
Right. Go ahead. Yeah. And gastritis and the peptic ulcer disease will not cause the fever.
Yes, sir.
You have to explain everything. You have to see for
Yes.
the vomiting, you have to see for the fever, pain radiating to the back, associated with the respiration, chills and
Yes.
right. So all those things has to be explained by one pathology.
Okay, sir.
So the other things which are there, you cannot. In the case of malaria, you don't have exclusive pain in the left upper abdomen,
Yes, sir.
As such, the patient will having the fever main presentation
Yes.
rather than the pain in the abdomen.
Yes, sir.
Dengue will have so many other pathologies which will be there. Okay, there may be joint pains may be there, which is not in your patient. So all those things. So that is why malaria and dengue should not be a diagnosis here. Okay.
Okay, sir.
Right. Go ahead. Yeah.
Yes.
Yeah, Dr. Varun, examination, please. Anyone, sir?
Yes.
Anyone else? Examination. Let's go to the
General physical examination. The patient was examined in a well-lit room after taking proper verbal consent. Patient was conscious, well-oriented to time, place, and person. There were no signs of dehydration present. There was pallor present. There were no signs of icterus, clubbing, cyanosis, lymphadenopathy, or edema. At the time of examination, the patient was maintaining a heart rate of 78 beats per minute with a BP of 126 by 80 mm of mercury. She had an oxygen saturation of 98% on room air with a respiratory rate of 16 per minute. She was afebrile at the time of examination, and a GCS of E4, V5, M6 was present. On systemic examination of the abdomen, on inspection, scar marks from previous surgical intervention were present at infraumbilical, epigastric, mid-clavicular line, and mid-axillary line. Fullness could be appreciated on inspection in the left upper abdomen. Non-distended, the rest of the abdomen was non-distended with no visible lumps. Umbilicus was central in position and inverted. There were no dilated veins, caput medusae, or spider angioma. There were no visible swellings at anatomical hernial sites. On palpation of the abdomen, on superficial palpation, there was no local rise of temperature. The abdomen was soft and no tenderness was present on superficial palpation. On deep palpation, the abdomen was soft with tenderness present in left hypochondrial region. Splenomegaly was present, Hackett's grade 3 classification. No other lumps were present. On percussion, dull note was present over the left hypochondrium region, extending up to 3 centimeters away from the umbilicus. Tympanic note was present over the rest of the abdomen. No shifting dullness was found. On auscultation, bowel sounds were present. On systemic examination of the chest, bilateral equal air entry was present with no adventitious sounds. On examination, S1, S2 sounds were heard. No added murmurs were found or heard. So based on the examination, I would like to keep splenic abscess as my first provisional diagnosis. And second would be hematological malignancies like lymphoma or myeloproliferative disorder. And then third would be malaria and hemolytic disorders, then hydrated cyst of spleen and metastasis.
Dr. Varun,
How come you're
can you hear me?
Yes, ma'am. Good evening, ma'am.
I just have some questions. Actually, from your history, you said that the patient came only with pain and fever,
Yes, ma'am.
right? And you say that obviously you can see a mass, visible mass. Don't you think the patient will say that she is having a lump in the abdomen?
Ma'am, on first of all, on deep palpation.
No, just your history on inspection itself. You mentioned that there is an visible mass.
Yes.
Can I see the inspection slide?
Yes.
Yeah.
Dr. Varun, have you got a picture of the patient?
Sir, no, sir.
Okay.
Fullness could be appreciated on inspection in the left upper abdomen. You can appreciate it by seeing. Don't you think the patient says she's feeling and she's feeling a lump over there, a lump
Yes,
which is you are saying of grade 3, and she can feel. I think she will come with a lump rather than coming only with fever and pain. And
ma'am,
as sir said, pain and fever never comes to surgery department. Fever goes to medicine department.
ma'am, the patient did have complaints of heaviness, which I have mentioned in the history.
Yeah, you
She
said
had-
heaviness.
Yes.
She will say a lump. It is quite obvious when you can see it. She will say a lump. And second thing, the common mistake that is being done, murmur is not a common sound that we can hear every time. It's only the S1, S2. So it's better to say no added sounds rather than saying no added murmurs. We
Okay,
don't
ma'am.
add murmurs,
Okay, ma'am.
right?
Yes, ma'am.
And that's it. We will come back. We have so many things.
Okay, Dr. Varun,
Yes,
let's
sir.
go to your regional examination.
Yes.
So there's nothing except for your palpable spleen in here, right?
Yes,
Next
sir.
slide. Next slide, please.
Varun, how do you say it is a splenomegaly?
So, on palpating the abdomen, on deep palpation of the abdomen, while starting from the right iliac fossa and moving towards the left hypochondrium, I could feel a lump with a notch, which I could assume as splenic notch, and the borders were sharp. So I was, and it was moving with respiration. So I can say it is spleen, sir, splenomegaly.
You were able to feel all the margins?
No, sir, only anterior margins, inferior margins.
Did you look for the trough space?
No, sir.
What will happen to the trough space here?
So it will get oblated, sir.
We should have mentioned that, isn't it?
Yes.
And you are able to feel the notch in this patient?
Yes, sir. Yes.
Okay.
Okay, let's go to your differential now.
Yes.
So your the differentials in your history have all got chucked out except for malaria, and you said splenic
sir.
abscess. Okay, hematological malignancies. Why have you come to that conclusion? Splenomegaly with anemia.
Because pallor was present first of all, and splenomegaly. So on those bases, and fever was
Was she
present.
very pale, or she was just mildly? You can, if a patient is very anemic, you can make out that she's very anemic.
I could appreciate it on examining the palpable conjunctiva, but she also had history of malaise and fatigue. So
No. Look, when you see a patient, you know, obviously this patient is fairly anemic, and this patient is very anemic.
Yes, sir.
So what kind of pallor was there?
So mildly anemic, not severely.
Mildly. So
Yes,
do you think in this kind of thing she would have mild, and then she would just have a 15-day history?
No, sir. Yes.
Hydrated cyst of spleen. Did you ask for her pets and all?
No, sir, but she had a local farm in the hilly area, in the hills.
Yeah. So you should, for hydrated, you should try to establish the cycle.
Okay, sir.
Right. I mean, if it's not necessary that she may have exposure, but then if she has exposure, it is an added information, right?
Okay, sir.
Metastasis from where?
Any
What?
any lung pathology or any other lung
Okay,
pathology?
but metastasis to where? Just to spleen? Your liver is not enlarged.
Yes.
And if it was a hemolytic disorder, wouldn't the liver also be enlarged?
Yes, sir. It would be.
Even lymphomas, I would expect the liver to be enlarged.
Yes, sir.
Right. So I think it would be better. What about, have you examined the renal angle? The back?
So I did exam, but there was no tenderness present. Yes, sir. There was no tenderness
No, but
present.
you've not written.
You have not mentioned it.
You've not mentioned it. No? Look, left side, for me, it is important that I rule out the kidneys. You've got spleen. I rule out the pancreas. I rule out the stomach. I rule out the lower chest wall, the pleural cavity, and the splenic flexure.
Yes, sir.
Right. And in women, even women, a pelvic disease, they can present with these kind of things.
Okay,
you may not get a lump.
Okay, sir.
But they can. Right.
Dr. Varun,
yes,
if
sir.
you take your history and examination both together, patient have short duration of history with pain and fever and tender splenomegaly.
Yes, sir.
Okay. So what differential you want to keep for these patients? Tender splenomegaly with history of fever and pain.
So I would like to keep splenic abscess.
What kind of this thing it is? Is it possible all the time to make out spleen clearly in patient with splenic abscess until unless it is parenchymal, intrasplenic?
So if the spleen is enlarged, then we can see on clinical
There
examination.
are so many causes for tender splenomegaly. Okay.
Yes. Yes.
There may be infective causes, so many other causes. Why did you keep splenic abscess only in patients with tender splenomegaly, where you are clearly able to make out spleen? You are saying you were able to make out this is tender spleen.
Yes, sir.
It is not stomach, it is not pancreas, it is not any other organ. You are very sure this is tender spleen.
Sir,
Why
because
did you keep splenic abscess as first diagnosis?
because she was having a history of complaints of fever with chills and rigor.
That was in the, there are so many causes you enumerated in your history after differential diagnosis. All the causes will have history, pain and fever.
So, but then there would be no tender splenomegaly.
Infective causes will have tender splenomegaly.
Yes.
So why did you keep this thing hydrated? Since it is usually tender splenomegaly in hydrated.
No, sir.
All hemolytic disorder will have this thing, tender splenomegaly. Metastatic, splenic metastasis will have tender splenomegaly.
Yes,
Is it
sir.
usual to have tender splenomegaly in metastasis?
Okay, sir.
Why did you keep this? Can you justify your differential diagnosis?
Sir, based on we can have lymphoma also, but then
You
sternal
can have
tenderness.
each and everything, but you have to, your diagnosis should fit on your history and examination. On imaging, it may be turned out to a rare presentation of any other disease.
Yes,
That
sir.
we are not discussing. We are discussing approach to a patient. Your approach should be good and
Okay.
should be focused to a common diagnosis which we really face. Okay.
Yes, sir.
Varun,
Yes, sir.
your examination protocol is not complete.
Yes.
Order of examination is not complete. You are not mentioned about considering the left-sided lump. You are not mentioned about supraclavicular area, spine, renal angle, external genitouria. You are not mentioned it. Most of the points are you are not covered. Because
Okay,
in
sir.
clinical examination, they are checking the order of examination, whether you are mentioning in a proper way or not.
Okay, sir.
And left side swelling, how do you differentiate splenic swelling from the left kidney clinically?
So, first of all, splenic swelling would move with aspiration. We could feel the
Okay.
notch. We could feel the notch, and the kidney is usually palatable, and we can, but spleen is not palatable.
Kidneys,
Kidneys are palatable, sir, on bimanual palpation.
palatable or bimanual palpable?
Sir, bimanual palpation we can do, and we can feel that the kidneys are palatable, sir. But spleen is not.
What is bimanual palpation and what is ballotment?
Sir, ballotment, sir, on bimanual palpation, we ask the patient to take either left or right lateral position. Then we keep one hand at the back and one hand over the over the anterior ventral surface, and then we can move the kidney. This is known as ballotable, and on feeling the kidney, that is bimanual palpation. But if we can move the kidney anterior posteriorly axis, then it is ballotable, sir.
What are different methods
I
for
think you are a
palpation?
little confused about that, You have to be very clear about the difference between the ballotment and the bimanual palpation.
All these are very basic questions.
In both cases, you will put the hand anterior and posterior.
Yes, sir.
In the case of ballotment, you have to push from one side to feel the lump on the other side.
Okay, sir.
So you can push from the posterior side and you can feel on the anterior side, or you can push from the anterior side and you can feel on the posterior side.
Yes, sir.
But in the case of bimanual palpation, you will feel the lump simultaneously. You are not pushing anything, but
Okay,
you
sir.
are feeling the lump in between your two hands here.
Okay, sir.
Most of the renal lumps, which are small lumps, they are
Yes,
ballotable.
Okay, sir.
But the bigger lumps, they are bimanual palpation.
Okay, sir.
So that is the difference between a ballotment and the bimanual palpation.
Okay, sir.
Yeah.
What are different methods of palpation of spleen?
So, first method on standing on right side of the patient, and after taking consent, we start. We put our right hand on the right iliac fossa, and we start palpating the abdomen and moving towards the left hypochondrium on every deep inspiration, and we feel the splenic inferior border of the inferior margin of the spleen or splenic notch at the fingertips. That is one method that we follow. And
Classical method.
yes,
This
sir.
is called as classical method from left iliac fossa toward the hypochondric, left
Yes.
hypochondric area.
Yes,
Second
sir.
method. There are 4 methods.
I,
Why don't you
sorry,
don't just say no and let him answer and then progress.
I can't remember about other methods.
Hooking, dipping, bimanual palpation. These are other 3 methods.
Okay, sir.
Hmm?
Okay, sir.
Okay, now how will you manage this patient?
So
Varun,
first of all,
when do you feel the spleen?
yes, sir.
What should be the size of the spleen to be palpable?
So usually, first of all, spleen is felt on deep palpation, and if it is
So
too,
how much should be enlarged? His question is, how much should it be enlarged to become palpable?
so for more than 1.5 centimeters, sir.
1.5 centimeters.
The spleen has to be enlarged at least
Doctor,
3 times of
1.5
original
times.
size, है ना? To become palpable.
Yes, sir.
Okay. All right. Now, your second diagnosis is the hematological malignancies.
Yes.
Now, when you suspected the hematological malignancies, what
Yes.
things you will look in the general examination of the patient?
So first of all, I would like to look for any sternal tenderness.
Good.
And so then cervical lymphadenopathy or any supraclavicular lymph node.
Okay.
And then I would like to ask in history
No,
for
the
any.
other lymph nodes which will palpate. The other
Yes.
lymph nodes will palpate. What are they?
So I would like to ask for then inguinal lymph nodes, axillary lymph node, and on Blummer shelf nodules and Krukenberg's.
Krukenberg, you'll palpate.
No, sir. We feel, sir.
Okay.
So
What
you'll
you will,
palpate the lower spleen and the lymph nodes, cervical, supraclavicular, axillary, inguinal, epitrochlear.
Yes, sir.
Right?
Okay, sir.
Varun, if it is a hemolytic anemia, then
Yes,
what
sir.
you will look on the face of the patient?
So there would be signs of first of all there would be severe anemia. So
Okay,
on
so that you're told, anemia you're told. What are the other things you are going to look in a patient with a hemolytic
so,
anemia on the
so
face?
there would be presence of petechiae or any rashes.
Okay, that's okay.
And so the face of the patient would be flushed.
No. Why would the patient have petechiae or rashes in hemolytic anemia?
So
Why
because
would the patient have, go on.
so because of hemolytic disorders, because of so small
Why do you get petechiae or rashes? Because of, you mean that there'll be some sort of bleeding disorder
so
or fragility of the capillaries?
so fragile capillaries, sir.
So you will get that in hemolytic anemia.
Yes.
You get fragile capillaries in hemolytic anemia.
Yes, sir, we can get, sir.
And of course, what is the cause of hemolytic anemia usually? What is the most common causes of hemolytic anemia?
So thalassemia, sir.
Thalassemia won't present in 15 days, please. Acutely hemolytic anemia क्यों हो जाएगा कभी इसको किसी को?
Sir,
बाकी जितने भी hemolytic anemia सब prolonged होंगे. Spherocytosis, sickle cell, all this kind of thing will have prolonged this thing, right? Acute में there'll be the transfusion or some reaction.
yes, sir. So,
So petechiae is not a feature of hemolytic anemia, please. That is because of either fragile platelets or bleeding disorder, coagulation disorder.
okay, sir.
Yeah, go on.
The other things on the face you will see for one is the
Sir.
depressed nasal bridge.
Yes, sir.
Okay, depressed nasal bridge.
Yes, sir.
Ask the patient to open the mouth and you see for high arched palate.
Okay, sir.
Okay, if you find in a patient with this, then you will suspect very strongly about the hemolytic anemia.
And
Yes, sir.
that's in chronic anemia. Chronic, okay, not in acute also.
Yeah, in
Okay,
chronic,
sir.
it is definitely in the chronic one, yeah, in the hemolytic anemia. Yeah. Okay, go ahead. How you are going to manage your patient now?
So, when the patient presented to us in emergency, we first of all checked her vitals, and after checking the vitals, we administered intravenous fluids and IV analgesics for immediate pain relief. Followed by we sent the laboratory investigations, which came out to be hemoglobin was 9.3, TLC was 20.8, and platelets were 384,000. Rest serum creatinine, serum sodium, and serum potassium were not significantly deranged. Her
The TLC was 20.8. Will you like to tell us about the DLC also?
sir, in DLC neutrophils were raised, sir.
Okay. So what are
And
the various features you can get in the differential count in the patient with splenomegaly?
sir, we could get neutrophilia,
Yes.
and if we are heading towards any uh, leukemia like CML, then we
Yes.
would see cytopenia and severely reduced cytopenia. And
You will not see any abnormal cells?
so a shift towards the left is seen.
What about RBC? Number
So,
of RBC, and will you
so if
see?
yes, sir, if we are suspecting hereditary spherocytosis or sickle cell, then RBC morphology would be deranged, sir.
No, morphology also. You see reticulocytes.
Yes, sir,
You've not
reticulocytes.
mentioned them. It's not mentioned here,
Yes, sir.
right? You see reticulocytes.
Yes, sir.
So you will see the blast cells.
Yes, sir.
Okay. You will see the very high total leukocyte count.
Okay, sir.
Okay. There may be lymphocytosis may be there. So all
Yes,
those
sir.
things, abnormalities can be seen when you're doing the CBC of this patient. You know?
Yes, sir.
And you should describe in this patient about the CBC. That is very important.
Okay, sir.
But once the patient is splenomegaly, we should exactly know that what is the CBC of this patient.
Yes.
Now, what is happening to the platelet count, what is happening to the red blood cells, what is happening to the white blood cells, what type of
What
the
about PCV? Your PCV is also not there.
Yes, sir.
Also, if you think there is all this CM and all, have you examined the oral cavity?
Yes, sir. There were no presence of any oral thrush. Or,
No, thrush is fine. They
yes, sir.
usually have thick
No,
gums which bleed.
no
Okay.
bleeding gums present, sir.
Yeah, so all that has to be mentioned now. In retrospect, when we go back now.
Sir.
Okay, go on, please. Next.
Now, sir, when the patient presented to us, she had a ultrasound whole abdomen done back at her village, which was suggestive of splenomegaly with a well-defined hypoechoic lesion, causing capsular bulge with mild perisplenic fluid along the bulge, with a differential of cyst squaring impending rupture. This was the.
Varun, I'll just stop you here. You've got the report. So I'm amazed. Why did you put malaria and dengue in your first differential? I mean, that's committing harakiri. That's committing harakiri, right? Everything is quite clear that it's a splenic abscess or a cyst or whatever, right? Chalo. Go on.
We did a X-ray chest PA view to look for any pleural effusion, which was not suggestive of any abnormality. So we planned the patient for a CCT abdomen plus pelvis, which was suggestive of spleen, enlarged spleen, measuring 15.5 centimeter. Also, there was well-defined fluid attenuation, cystic lesion measuring approximately 10.2 centimeters, with multiple air density foci. Also, the spleen was seen of the stomach. Rest, there was no any other abnormality reported in the CCT abdomen, and the impression was splenic space-occupying lesion features suggestive of splenic abscess with impending rupture.
Okay. Okay. So where do you think is the focus of infection? In a diabetic patient with splenic abscess,
Yes, sir.
where would primary splenic abscesses is very uncommon.
Yes, sir.
There's got to be focus somewhere. Where do the focus generally come from?
So it could be due to infective endocarditis. Usually splenic abscess is present.
यार तुम medicine को छोड़ दे मुझे यार, please spare me यार. तू endocarditis, pleuritis मेरे सामने मत बोला कर, please. We are surgeons here. Think of a surgical cost.
So in pseudoaneurysm of splenic artery, sir.
Okay, spleen का supply, blood supply कहाँ से है?
The celiac trunk से splenic artery आती है, sir.
Okay,
and that supplies the spleen. Usually it is.
And the splenic vein? Splenic vein? Where does the splenic vein go?
So it joins the superior mesenteric vein to form the portal vein, sir. So
what's the function of the spleen?
So usually, first of all, it acts as a graveyard for RBC, as we learned in MBBS, and it usually removes the old age senescent RBCs. Then it acts as a filtration for.
Right. So it filters.
Yes.
So where do you think is the blood coming in a patient? She has undergone cholecystectomy, hasn't it?
Yes, sir. Yes, sir.
So where do you think the infection would be focused from now?
From the pancreas, as
either from the CBD or from the gut. We'll look of these areas now, which will feed the spleen.
Yes, sir.
Okay. Yeah, go on.
These were the images of the CT, and we could see over here. This.
Okay, hang on. You think what is it, a CCT or what kind of contrast have you taken?
So IV contrast.
Just IV, no oral?
So no oral, sir.
Why? Why do you think there's no oral? Okay, so, why do you think it's IV contrast?
So because we can see the aorta.
So this is in the arterial phase.
Yes, sir.
Okay.
And this is the coronal section of the CT, and in this we can see over the left side the splenic abscess.
So why do you think oral was not given? Oral contrast was not given.
So because we were not not suspecting any.
Suspecting?
So we were not suspecting of any intestinal pathology or obstruction that we had to give oral contrast, and we gave IV contrast to
okay, that's not the reason. If you give an oral contrast, the contrast in the gut may obliterate the view of the spleen.
Yes.
Right. Similarly, in CA pancreas or head of pancreas, when we do, we give oral neutral contrast. We give them water.
Okay, sir.
Right. We don't give them a radiopaque contrast because that obliterates the organ we want to see.
Yes.
Right.
Varun, are you sure the contrast has not been given orally in this patient? I think the contrast has been given in this patient, but it is a small amount.
Yes, sir.
Okay. Because you can see the loops of the intestine.
Yes.
Yeah, they usually give water or a very thin barium.
Gastrographin has been given.
Yes, sir.
Okay, gastrographin has been given in this patient, but very small amount has been given.
Yes.
It's not that it has not been given.
Yes.
Yeah.
In this picture, we could see the splenic abscess and the septa with air foci.
So what is the significance of that air in this?
Sir, infections, sir.
So what is the
Infected
thing which is causing this problem in this patient? Why there is air in this?
The gas-producing bacteria. Gas-producing organism could be.
And your patient has? What is the precipitating factor here?
Sir, history of cholecystectomy, sir.
No, cholecystectomy not there. Anything else?
Diabetes, sir.
Yeah, diabetes is there. Okay. This patient has a diabetes.
Yes, sir.
And this is just like what is called the emphysematous one.
Okay, sir.
Okay. So that is why you are finding the air in that.
Okay, sir.
Okay. Right.
The patient was planned for splenectomy, but the OT was deferred as the attendants refused to give high risk. So on the following next day, the patient developed severe pain and tenderness in the abdomen with abdominal guarding, following which the patient was taken up for emergency surgery. A diagnosis of ruptured splenic abscess was made, and intraoperatively, pyoperitoneum was found with approximately 4 liters of purulent material. Abscess cavity was seen originating from the hyla of the spleen, abutting the stomach towards the greater curvature. The patient initially was planned for splenectomy, but since there was no evidence of any bleeding, a perisplenic drain was placed and splenectomy was deferred. These are the images, sir. And we can see this spleen, and this is the ruptured abscess. Over here, sir.
Okay, if your patient was not ready for the surgery, he was not giving consent, could you have done something else in this patient?
So we could have gone for a percutaneous drainage ultrasound guided or CT guided, but since there were loculated cyst on CT, we planned for splenectomy, sir.
No, the patient is not giving consent for that.
Yes,
Yeah.
sir.
So why did you go for aspiration status? Okay, we'll aspirate then. Why did you have to say, okay, I'll take a high risk consent and operate only?
So the high risk consent was from anesthesia side.
Whoever it was, that was an alternative for you instead of letting it to rupture. Look, mortality increases many folds after rupture, isn't it?
So have you done the splenectomy in this patient or not?
No, sir. No, sir. We did not do splenectomy. So because in this photo, as we can see, as the abscess ruptured, we could see that this is a ruptured abscess, and there was no evidence of any bleeding. So we just placed a perisplenic drain, and we did not go for splenectomy.
But do you think you are happy with that? This patient will come back with the abscess again?
So we did a lavage, and we can in the postoperative period we can go for antibiotics.
Varun, what sir is trying to ask you that ideally for splenic abscess, such a large one in a diabetic patient, the treatment was splenectomy.
Yes.
Right? Why did you like to save the spleen in this patient, or whatever the portion was? Any reason for it?
So since the abscess had already ruptured and we had drained the purulent material intra-abdominal that was present, and on the spleen there was no bleeding present. So if we had gone for splenectomy, patient would have suffered from other postoperative complications also. So we just placed a drain.
Okay, you did it. No problems. Okay, someone's asked why is it not a pancreatic abscess? I mean, the CT is showing clearly that it's a splenic abscess, nothing to do with pancreas. So it's not a pancreatic. Yeah. Okay. So you've done the splenectomy. You
Yes.
put a drain.
Yes.
What was the post-op?
So in the postoperative period, patient was transfused with 1 unit of PRBC.
Why
And
did you do that?
so because initially in the pre-op, patient had a HB of 9.3. And when we had planned the patient for elective splenectomy, patient refused. But the next day, when patient developed signs of rupture, like severe tenderness in the abdomen, we had taken her for emergency OT.
So what was the
we,
hemoglobin next day?
so next day, the patient had a hemoglobin of 10.2, sir, 10.4.
So, I mean, okay. My concern is, why did you have to give a PRBC? What are the indications for giving up a blood transfusion in a post-op patient with splenectomy?
So if it is less than 8, then we...
Okay, so that's out. Anything, any other reason? What was in the drain?
So on the first day, on POD 0 and 1, it was on POD 0 only, so it was hemorrhagic, but in the subsequent days,
No,
it was...
I mean the amount.
Initially, it was only 100 ml on POD 0.
Yeah.
Then the following
Okay.
days, POD, yes, sir, it came out to be serous sanguinous with 50 ml and gradually reduced.
So I mean,
and on POD 4, we removed the
giving
drain.
blood for blood's sake is a bit too. There are a lot of risks for transfusion, isn't it? She had no fear. Was her pulse rate normal? Was her BP normal? Was she stable? Right, all that kind has to be taken. Anyway, yeah. Okay, sir, please.
The postoperative day 1. And
when did you discharge her?
So on POD 6.
So what do you tell her
On
before
POD 4, we
discharge? What
removed
do
the
you do
drain.
before discharge?
So before discharging the patient, we had advised her the immunization that we had to give in patients in post-splenectomy
No, she advised her or did you give her?
who have planned for splenectomy, sir.
Hmm?
We gave also.
You
We
gave her.
gave also immunization.
Okay.
What was the
So
immunization you have given to this patient?
The influenza B vaccine and first quadrivalent vaccine of Neisseria meningitis.
bivalent, trivalent, pentavalent, quadrivalent
Pentavalent vaccine of and pneumococcal vaccines.
When it was given?
In the on POD 2 we gave
the vaccination. Yeah.
So on POD 2 we gave
you don't give it on
and
POD2,
pneumococcal vaccine,
please.
sir.
Varun, you don't give it on POD2. The earliest you start is post-op day 3. It's usually at time of discharge.
Okay, sir.
Before discharge. And what vaccine is usually given?
So pneumococcal and Haemophilus influenza B vaccine.
Just that too. You give
Yes,
a
and
trivalent.
pneumococcal vaccine.
You give a trivalent.
Pneumococcal vaccine,
meningo,
sir.
and H influenza.
Yes, yes,
Right?
sir.
You give a trivalent.
Yes, sir.
If you have to go for elective splenectomy, when do you give the immunization?
So we can give in the pre-operative period also, so 14 days.
At least 2 to 3 weeks prior to the operation.
Yes, sir.
2 to 3 weeks prior to the operation.
Yes.
Okay. Now, when you are doing a splenectomy, you know, what are the various ways to carry out the splenectomy?
Yes, sir. We can do the procedure, sir.
Hello?
Hello. Yes, sir. So we can go for an open splenectomy or a laparoscopic splenectomy, sir.
Okay. Tell about the open splenectomy. The
So
patient is having, okay, I will give you the scenario.
Yes,
One
sir.
patient is having a hemolytic anemia.
Yes, sir.
Second patient is having portal hypertension.
Yes, sir.
And third patient is a trauma spleen.
Yes, sir.
Okay. Now tell the various differences in carrying out the splenectomy in these 3 scenarios.
So first of all, in traumatic patient, we'll go for an open splenectomy. And
Go for
in
a
case of
laparoscopic also, you can go for but I am asking only for the open one. Yeah. Tell about the open. Yeah.
so in an open procedure, so we first give a left subcostal incision, and
Trauma
after,
patient.
so trauma patient will give a midline laparotomy incision, sir.
Yeah. So tell one by one. In a trauma patient, you will always do a midline laparotomy, never a subcostal.
Yes, sir.
Okay.
And yes,
And then how you do the
yes,
splenectomy
sir.
in a trauma patient? Trauma spleen is usually a normal size spleen, isn't
So
it?
after yes, sir.
Varun, are you able to hear me?
Yes, sir. Yes, sir. Yes, sir.
Traumatic spleen is usually for a normal size spleen. A young patient
Yes,
gets
sir.
a trauma, it's a normal spleen there. So
Yes,
if
sir.
you have to carry out that, how will you do that?
So so we can after giving them midline laparotomy incision and visualizing all other intra-abdominal organs for any bleeding or
Okay, that's
trauma,
fine. Yeah, yeah.
we'll we'll uh, we'll 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 go towards the spleen, and we'll first dissect the divide the gastrosplenic ligament and ligate the short gastric vessels.
Will you get
Then
the time for all
we'll
these things?
divide the.
Will you get the time for all these things in a patient with a trauma?
No, sir.
So you are doing a splenectomy for a normal size spleen.
Yes.
There may big hematoma may be there, and
Sir.
you got a very short time with you.
Yes, sir.
So what
So
action you are going to take?
So we'll just try to divide the spleen from the surrounding peritoneal and adjacent ligaments and end block resection.
Okay, Varun, what are the ligaments? Tell me the ligaments first.
First of all, gastrosplenic ligament, then splenorenal ligament, splenophrenic ligament, and splenopolic ligament.
So which ligament you are going to divide in a patient who has a normal spleen? Again and
Yes.
again, I am emphasizing, it's a normal spleen. So you do not expect any adhesion in that area. So what are you going to do? You are going to divide only one ligament there. Which is that ligament? How many layers of the linorenal ligament are there?
The anterior leaf and posterior leaves.
Yes, there are two layers. So you are only going to divide the posterior layer of the linorenal ligament.
Yes.
And bring out the specimen or the spleen on the surface.
Okay, sir.
So that you can immediately take care of the pedicle.
Yes, sir.
Okay. So that is the way you are going for a traumatic spleen. You are not going to look for the gastrosplenic ligament there. First, you have to divide the posterior layer of the linorenal ligament, bring up the spleen on the surface, and then you immediately apply the vascular clamp there.
Yes, sir.
Now tell, in a case of a hemolytic anemia,
yes, sir,
how you will do a splenectomy.
So we'll give a we'll first of all we'll give a subcostal incision.
Okay.
And then we'll identify the spleen, and then we'll divide the gastrosplenic ligament. First we'll ligate the short gastric vessels, and then we'll then we'll divide the gastrosplenic ligament, followed by division of the posterior leaf of the linorenal ligament, sir. This way, we are able to mobilize the spleen, and
what you have to take care when you're doing a surgery for the hemolytic anemia?
So we have to transfuse blood also.
No, we are talking intraoperative here. Intraoperative things you have to check when you are doing a surgery for the hemolytic anemia.
So tail of pancreas, sir.
That you have to see in every case.
Yes, sir.
What is splenosis and what is spenculi?
So I can't remember.
Splenosis and what is spenculi?
So I can't remember, sir.
Spenculi is the accessory spleen which is there.
Yes, sir.
So you have to always check in a patient with a hemolytic anemia
Yes,
that
sir.
does the patient has got any excessive spleen. And the commonest site for that is the tail of the pancreas. It can occur in the other
Okay,
areas
sir.
also. So you have to check for
Yes.
that. And
Okay, sir.
splenosis is, what is splenosis? That
So
you should be sure that your spleen does not rupture.
Okay, sir. So
Because if the spleen ruptures, the spleen will get adhere to the other areas and it will grow there.
Okay, sir.
Okay. And your purpose of carrying out the splenectomy will be lost in that.
Yes, sir.
Okay. So that is the thing when you're doing it for the hemolytic anemia.
Okay, sir.
Now tell when you are doing it for the portal hypertension, then what you have to do?
So in case of portal hypertension, so there would be variceal bleeding also. So the patient will be having variceal bleeding also. In that also we'll
In a case with a portal hypertension, what are the problems?
So first of all, there would be portosystemic shunting, which would have led to
There will be
dilatation.
a lot of collaterals will be there.
Yes, sir. Yes.
Lot of adhesions will be there.
Yes, sir.
And it will be a very large spleen usually.
Okay, sir.
Okay. So what is the first thing you will do? If you are planning for the splenectomy, what is the first thing you are going to take?
So
you are going to open the lesser sac.
Yes, sir. Gastropolyps.
Take control of the, no, not the gastro. You are always after the gastrosplenic only. You have to take control of what? After opening the lesser sac.
What are the feeding vessels which cause bleeding in portal hypertension?
The esophageal varices due to
you can't reach the esophageal varices then. So niche, when you're doing splenectomy, what vessel are you going to reach? You have to secure the splenic vein, na?
Yes, sir.
Okay, when you open the lesser sac, the first thing you are going to do is ligation of the splenic artery there.
Okay, sir.
Okay. And take control of the splenic vein. You will not ligate the splenic vein.
Okay,
you will ligate only the splenic artery.
Okay,
so
sir.
that the blood supply to the spleen becomes less.
Yes, sir.
And the blood goes into the circulation.
Okay, sir.
Okay, so that is the way you are going to do in the portal hypertension. And then all these ligaments which are there, they are very vascular in this.
Yes, sir.
So you have to be very careful that you are dividing all these ligaments under vision.
Okay, sir.
Okay, so these are the three different ways to carry out the splenectomy in the different scenarios.
Okay, sir.
Okay. Now tell what are the various complications which can occur in a case of a splenectomy?
So first of all, in the immediate postoperative period, patient can develop
intraoperative. First tell the intraoperative, then early postoperative, and then late postop.
Intraoperative patient could develop hemorrhage.
Hemorrhage from where?
Splenic artery, sir, due to severe bleeding.
Yes, one is splenic artery.
Yes, sir.
What are the other areas which can bleed?
So short gastric vessels, sir.
Yes.
And then, sir, intraoperatively, if we on dissecting the spleen, we injure the tail of pancreas.
Yes.
We can injure the tail of pancreas also. Then intraoperatively, we can injure the cause injury to the colon at the splenic flexure, sir.
Yes.
And we can also cause injury, traumatic injury, iatrogenic injury to the diaphragm.
Yes.
And then, sir, in the post-operative period, sir, in the early postoperative period, patient could develop same signs of intra-abdominal bleed in the postoperative period. Then
What
hematoma.
are the various types of hemorrhage? Various types of hemorrhage. What is primary? What is reactionary? What is secondary?
So primary due to the initial cause, like intraoperatively, there's a rupture of the artery. That is primary hemorrhage. Then, sir, within 24 hours, it is reactionary. And secondary, sir, would be after 7 days, sir.
Because of? Secondary occurs because of?
So infection, sir.
Infection.
Infection.
Yes. Okay. So tell the other complications post-operative.
So in the postoperative period, patient could also have shortness of breath due to pleural effusion, sir.
Okay.
Or there could be pneumothorax,
Yes.
and there could be.
Varun,
Yes.
Varun, sorry to interrupt you. What is most common complication of the splenectomy? This is commonly asked neat question.
So left lower lobe atelectasis.
That should be first.
Yes, sir.
Okay. Then
Then,
next.
sir,
Continue.
then, sir, apart from pneumothorax and pleural effusion, patient would also have in the postoperative period signs of features of colonic injury or any and bowel injury. Then patient can develop pancreatitis or any pancreatic fistula. And then in the late and delayed gastric emptying also, sir.
Tell about
Then
the what are the
late
early complications?
gastric emptying.
So emptying, sir.
Now, will you examine the leg of the patient who has
Yes, sir.
undergone
So
splenectomy?
for DVT, sir.
Yes.
Yes, sir.
So DVT is one of the early complications of the. Okay, so hemorrhage may be there, infection may be there,
Yes,
lung problems may be there, DVT may be there, and if you damage any organ there,
sir.
then there can be complication because of that.
Yes.
Okay. Now, delayed complications.
So the patient can experience OPSI, sir, that is overwhelming post-splenectomy inflammation.
What is OPSI? What is OPSI?
Overwhelming post-splenectomy infection, sir.
Okay.
Usually, it has we can see the patient going in 3 stages, which are first of all prodromal phase, in which the patient might develop fever or fever, fatigue. Then in the next phase, patient can develop respiratory distress, followed by in the last phase, patient can go into shock and death, eventually coma and death, mortality, sir.
Okay. What are the changes occur in the blood after the splenectomy?
So first of all, post splenectomy, we can in a blood picture we can see the Howell-Jolly bodies, Heinz bodies, Pappenheimer bodies, and there would be presence of senescent or old-aged RBCs. Then we could see acanthocytes, sir, and target cells also can be seen, sir.
Okay. Now you have done a splenectomy in a patient, and after 5 days you find that his platelet count is 5 lakhs.
Yes,
What are you
sir.
going to do? Did you get my question?
Yes, sir, I did. I got your question, sir.
Yeah. Okay, we will start the patient on the aspirin.
Okay, sir.
Okay. Now the count is 7 to 8 lakhs. What you would do?
So I'm not.
So you will give the patient the prophylactic anticoagulation.
Okay, sir.
So you can start the patient on heparin
Okay,
or
sir.
NOACs. You know
Okay,
what
sir.
are NOACs?
Sir, novel anticoagulants, sir.
Yes. You know any name of that?
Sir, Enclex, Clexane. Clexane, sir, Clexane.
Clexane is not NOACs. Clexane is the low molecular weight heparin.
Sir, glycoprotein 2B3 inhibitors, apixaban.
Rivaroxaban, apixaban, all these are the.
Yes, sir.
So you can either start the patient on the low molecular weight heparin, or you can start the patient on the rivaroxaban. No, that is one of the NOACs which is there, which can be started.
Yes.
Otherwise, the patient is very likely to have the DVT.
Okay, sir.
Okay. Anybody else want to ask? Otherwise,
Dr. Varun,
Yes, sir.
how do you know that your splenectomy has been complete? Has that question been asked?
No, sir.
Okay, how do you know that you've after you've done a splenectomy, the splenectomy is complete?
So there's no. So there's no remnant tissues.
How will you know though? How will you know that there's no remnant tissue? तुमने बंद कर दिया patient को या how do you know that there were no spleneculi or perisplenosis or anything? If you do a blood smear, you'll
Yes, sir.
if you find Howell jelly HJ bodies
sir.
and inclusion
Heinz
bodies.
Yes, sir. Howell Jolly
Right.
bodies, Heinz bodies, and Pappenheimer bodies.
All these inclusion bodies, if they are seen, that
Yes,
means.
sir.
So how
The
does the spleen remove these bodies? How does the spleen remove these bodies?
So by filtration of sir, usually.
No, filtration तो यार वो तो Senate RBC को खत्म कर देता है.
Yes, sir.
These are there in the RBC. What is pitting and what is culling? Have you heard of it? Pitting and culling?
No, sir.
Culling मतलब मुर्गी का गला को काटते हैं ना, culling. So here the RBCs containing the inclusion bodies are killed by the spleen. Yes. And pitting means they dip into the RBC and pull out those inclusion bodies.
Okay, sir.
Right. So they are the two ways. Okay. Anything about you said about malaria? Suppose it was an European who underwent a splenectomy and coming to a malarial area. What advice would you give them?
So to get a prophylactic chloroquine dose, and
Either you get those malarial shots or you get. Okay. I think we're done. I think we're sufficient. So, Professor Khanna?
Yeah, I think we can close it here. Dr. Kanagaval?
Yes, sir.
I don't know whether he's there or not.
So, please, sir.
Hello. Sir, am I audible?
Yes, sir.
Hemant, please.
Yeah. So, good evening, sir. So, I have just want to have your comments on some of my queries. As sir said, it was right, sir said, before thinking about the medical causes, you should have thought of the renal infection, that is nephritis in a diabetes patient. But because he knew the diagnosis early, he came to me, sir, how should I present? I said, how the patient comes to you, you should present like that. The patient already came with the ultrasound, showing that there is a splenic cyst in it. query abscess. And most of the patients, they come to the medical college, they already have few investigations. So we always ask our students, don't see those investigations. You start taking the history and make a provisional diagnosis first without seeing those investigations. Then you should progress. No, what were the investigation? Which investigation you will advise? So in the case presentation, if you already have investigation, so you should start with that perspective, or should start afresh without
So
doing the investigation.
Even without his ultrasound,
Yes, sir.
It is quite clear that it is probably a splenic abscess.
No, sir, I think, sir, with the fever, vomiting, and pain left upper abdomen, splenic abscess is not a very common diagnosis.
No, what I'm trying to say is that there are two ways. Either we say, I don't know the investigations, even if I know, I keep it out of my mind, and then I come to a differential. But coming to a differential was dengue and malaria is not acceptable in a surgical forum.
No, sir. The case comes not as a medical case or the surgical case to the OPD or the emergency.
No, otherwise also. I will look for a surgical case.
Because he asked me, sir, splenic abscess. I said, how you can say splenic abscess with the, there will be more common other diagnoses with the pain, vomiting, and like fever.
Dr. Nautia,
this is just my question, sir.
Right. I will look for a surgical cause. And my surgical cause would be starting with the kidneys, starting with the pancreas.
No, sir, I fully agree with you. But when the case presents to the OPD, it's not always that is a surgical case. Like in our institute, there's a policy, pain abdomen call is given to the surgeon in the emergency. That's why this case came.
It's there everywhere. Pain abdomen usually goes to the surgeon.
Yeah, that's why this came with the, in spite of having a fever and vomiting, this came
in spite of that, if I'm there, I will not think of malaria or dengue. My first thing, if the patient walks into my OPD, if it's a medicine case, I will rule out the surgical causes and then go back, then hand it over to the physicians. You rule out the rest of the stuff.
No, sir, that is right. That is after clinical examination, because that first he was asked, what is your clinic, just based on the history.
Okay, let's see.
So it is different based on the history. Then clinical examination, investigation, the things will clear out.
So why do you think it's malaria or dengue?
No, I am not saying. He knew his clinic abscess and said, what do you think you presented? I will not guide you, because preparing a student and then he is presenting, they will not serve the purpose.
Exactly.
That will not serve the purpose, because I knew splenic abscess, he knew splenic abscess. I said, whatever you think,
so what is the differential so that you learn from the. Yeah. So what is the differential of splenic abscess? Would be the differential here?
Yes, hello?
The differential of splenic abscess would be differentials here.
Yeah. Obviously, sir. Once he has examined that there is a splenomegaly, then he can think of the splenic abscess as the first thing. Fever, high-grade fever, and the enlarged spleen. Then
in history, history, can just, if you can't, I can't figure out anything. I say I can't figure out anything.
Yeah.
Not being able to put anything.
Maybe that's why he was giving all those common diseases prevalent. And second question is like, sometimes after the examination, there is a splenomegaly. Can we take a retrospective? We often take a retrospective history, but can we include it? Can be included in the history?
Yes, we can.
Because this then student will be asked why based on
MRCS guidelines they say. In MRCS guidelines they say you go back to your history to confirm your.
No, sir. Like when we teach them, the patient comes with the complaint. He gives a chief complaint. They elaborate on the complaint, and then we ask what is the provisional diagnosis 1, 2, 3 or differential diagnosis. Then on examination you find suddenly a different thing, and then we take a retrospective history, give whether there is history or not. But whether that should be included initially in the complaint or not. Taking a retrospective history totally different. Otherwise, examiner asks why you have taken this history. Suddenly you have taken a history of bleeding disorder or a hemolytic anemia. What is in the fever, vomiting, and pain upper abdomen? Why do we take in every patient an history of hemolytic anemia, which will cause splenomegaly? Because we still don't know anything.
Not a surgical disease itself.
My question is, should that be included by the resident in the exam retrospectively? Then the examiner asks, why you have taken this history? What is the relation with these complaints?
Hemolytic anemia.
Basically,
I think Professor Khanna, sir. Come to the rescue.
Yeah, I think Dr. Hemant, you are asking very good query. I do agree with you. When you are sitting in the busy OPD, Can you hear me, Dr. Hemant?
Yes. Very.
Okay. When you're sitting in a busy OPD and a patient comes with a fever and pain abdomen, majority of the time you'll refer this patient to the medical department.
Yes.
Okay. Now, because the patient in the surgical department, you are right that you can keep a diagnosis of malaria and all these things in your patient until
No,
unless
that is
you examine the patient.
Yeah, that was the
Okay.
thing, because
we
asked the
until unless
resident
you
to
examine the patient, you were
Yeah.
only telling, he was only telling on based on the history only.
history. Yeah, that is my question, sir.
Yeah.
Sir.
So yeah, based on the history, you are right in saying that he can keep a possibility to the malaria and the dengue and all those things. But
Yes.
once you examine the patient, then all those
Yeah,
things will stop,
then obviously, sir, the surgical causes will take a
definitely.
precedent.
Yeah.
And
Sir,
second, sir, introducing the retrospective history into the primary history.
Yes.
Sir, Professor Khanna.
Yes, please.
Sir, please, may I just put, sir, even if I am in a surgical listing, my first after history will never be dengue or malaria, sir. मैं तो नहीं
Correct,
रखूंगा.
sir. Correct.
Okay, second, sir, what about that? Introducing a retrospective history into the present history.
Yes, sir.
That is acceptable,
You will not allow the student to have a retrospective history and then presenting as if he has taken that history.
No. You know what happens that even in the examination, if your diagnosis is becoming like that, like as I said, it's a hemolytic anemia, then the student will go back and will examine his face for the IR's palate, whether there is any depressed bridge is there or not.
Sir.
So all these things he will examine. If it's a leukemia case, he will examine the alveolus of the patient, that whether the gums they are thick or not, they are bleeding or not. Sternal tenderness he is going to see. So definitely, it is not that it is going on in one way. It will also go retrospective also,
No, definitely, sir. On examination.
Yes.
But introducing those questions into the present history, that will be wrong. That means when we say we have to present a history, chief complaint and the version.
So can you give an example in this?
No, but based on your examination finding also, the student will go back and ask those relevant history.
That's it, definitely.
He will go and ask for that.
That is right.
So that should be included. There is no problem in that. There is no problem in that. It should be included both in the history and the examination.
Sir, sorry to interrupt you that. Sir.
Please.
Sir, I agree with you. But what we are assessing from the student, we are expecting the order of examination and approach towards examination.
No.
Yes, right.
This is not a straight model, You have to modify the models according to what scenario is there.
No, sir.
So if a patient on examination, you find the patient has some positive finding, then you have to go again back on the history.
Sir,
all those things.
He has to go and take that history.
Yeah, definitely.
But how to present in the initial phase when he's presenting a case?
No, he is going to present that. Now,
like for example,
once he has examined the patient,
then he should say that
there is some
I have taken
finding
this
is there.
History. That is okay, I think.
Yeah.
That was okay. And another thing, sir, please advise me, because when my AP called me, there was a ruptured abscess. The day one, the patient refused the high risk, and then the next morning, the patient had severe pain and tenderness. Then they agreed for the high risk surgery. And then my AP called me, sir, this is ruptured splenic abscess. You please come for the splenectomy. Then I went there. My plan was splenectomy. I started mobilizing. Then I noticed that there's no bleeding. It was abscess was in the mid and the hilar region, and the hilar vessels were safe. They were not bleeding, and it was just spleen was just like it is cavitatory lesion in the middle part of the spleen. Upper pole, lower pole was okay, and there was no bleeding taking place. So then I decided why to go for splenectomy in this sick patient who is having for 10 days last pneumogaly. If we save this spleen, what is the harm in that? So that's why I took that decision. So please guide me, sir. Please guide me.
It's right. Your decision is right.
That
was also done the same thing.
Yeah, I had gone with the intention of doing
there's no doubt about it. There's no doubt about it.
Yeah, so that was just suddenly we changed our decision.
I beg to differ to that, This is a disease spleen. Okay, we are not talking of a traumatic spleen where we can go for a splenography in that patient. or you can go for a partial splenectomy in a young adult with a normal spleen. But here is a disease spleen is there. And if you are technically able to carry out the splenectomy in this patient, I will go for a splenectomy. But if it's fine, there's a lot of adhesions are there and a lot of bleeding is there and all those things,
Not
then
adhesions,
probably you can get away with only draining that abscess. But otherwise, because there's a central abscess which is there, and it's a disease spleen because of the big abscess which is there, I will prefer to go for a splenectomy in this patient if it's technically feasible. If it is technically difficult, you think that you are going to damage the colon and you are going to damage the pancreas and all those things, or the diaphragm, then it maybe you may
no,
come out.
Technically it was feasible, sir. But I changed my decision because
I think my decision will be if it is technically easy, you can go for a splenectomy in this patient.
Because now they say if even if splenic abscess is there, the radiologist is ready to drain it, ultrasound guided aspiration or drainage.
That can be done. Yes.
So in all cases, we are again leaving the spleen, and it is the focus can come from anywhere, hematogenous spread, and it is a diabetic patient. So rest of the spleen is okay, I think.
Yes, so the gold standard is splenectomy, like sir is saying. But there are several studies which are saying that we can, if you think the rest of the spleen is healthy, and you can. The gold standard is splenectomy, like sir said.
It was not bleeding, sir, from the cyst cavity margin. It was not bleeding at all. So that's why we changed our decision just one.
Okay, how is the follow-up of this patient after that?
The patient did very well in the post-op. She was discharged on the day 6. There was only 70 to 80 ml serosanguinous discharge on day 1. No bleeding at all. Otherwise, I would have done splenectomy. I went with the intention of splenectomy. My AP called me for splenectomy.
But it was not a hydrated cyst, is it?
That was, sir, one thing which it was on mind, and he missed to take the biopsy from the wall. But there was no such separate thick wall. It could have been. Infected hydrated cyst could have been a possibility. It could have been a possibility, sir. I agree with that.
Okay.
Okay, thank you, sir, for your advice.
Varun, you want to ask any question from us?
No, sir.
Okay. I think Dr. Kanagal is back. Yeah, Dr. Kanagal, we have finished. Yeah.
Madam Sushma, would you like to comment anything, madam? Madam, you are in mute mode.
No, sir, I think it has been extensively discussed each and every part.
Thank you, thank you. Dr. Varun, would you like to ask any doubts or any questions to be clarified?
No, sir. No, sir, not as such, sir.
Thank you very much. Any other faculty would like to give their comments? Fine. So thank you very much, faculty. Thank you, Hemant sir, for bringing in a tough case for us. It evoked a lot of different axial discussions, but then eventually the management option lies with the operating surgeon and the operating team, because you get the first-hand information of what needs to be done. Radha ma'am, do you have any questions? Okay. So thank you very much for everyone for joining us this evening. We will meet coming Friday. So anyone who are here wishing to present a case, you can reach out to me, or anyone, any faculty who would like to contribute also, you are welcome to reach out to us. So good luck to all of you. Sir, Kanna sir, like sometime back, we were talking about the online lectures which need to be recorded. So they have asked me again, what are the topics we would like to cover? So when time permits, please go through that and let me know, sir, what are the talks we would like to give, and they will arrange for recording the talks. All the faculty.
I have already given you my topic, is it?
So you let me know when you would like to, when you are prepared for giving the talk. When you are ready.
In this forum, or it is a different forum?
Sorry, no, sir, not in this forum, sir. That will be a different forum. It will be recorded and kept online, sir. Not by us, sir. It is by a different group.
Okay.
So whenever you are ready with your PowerPoint and when you are giving the talk, at your convenience, sir, morning or evening does not matter. They will be prepared to do the recording on.
Okay.
Thank you very much, all the faculty. Please keep in touch by WhatsApp so that I will be able to do the recording part at your convenient time.
Right. Okay.
So thank you, Dr. Varun. Thank you, Hemant sir.
Thank you, sir.
Thank you all the faculty for making